Are you all comfortable?
Yes.
Okay, good. Today I'd like to talk about reducing the risk of contrast material-induced acute kidney injury. You all have taken the pre-test, and when we're done with the presentation, little teaching project today, we'll take a post-test and see how much you learned. I'd like to start by giving you a little preview of what we're going to talk about and learn about today. I want to talk a little bit about contrast material-induced acute kidney injury, abbreviated CI-AKI, and specifically CI-AKI related to percutaneous coronary interventions, abbreviated PCIs. CI-AKI is a significant problem, and that's something I'll take a little time to point out as we're going through the session today. I'd also like to talk about protocols proven to decrease the likelihood of developing contrast-induced acute kidney injury. And finally, what nursing interventions can be employed to reduce the risk of developing CI-AKI. The material I'm going to present draws largely from this source. It's a study by Lambert and others, the title of which is Reducing Acute Kidney Injury Due to Contrast Material, How Nurses Can Improve Patient Safety. That was published in the Journal of the American Association of Critical Care Nurses in February of 2017. Okay, so let's talk about CI-AKI. The contrast media, as you're all aware, being healthcare professionals and nurses yourselves, student nurses, soon-to-be nurses, you're aware that contrast material used in catheterizations is, in the cardiac catheterization lab, is nephrotoxic. It's toxic to the kidneys. It is capable of doing kidney damage. And regardless of whether the patient has healthy kidneys at the time or not, any patient exposed to that contrast material is at risk for acute kidney injury. Okay, so here I have a slide, and you see the outline of the heart here. And you all have this on your, I handed this out before we got started. You all have this sheet of paper with this on there. But in a cardiac catheterization, they run the catheter up to the most proximal point of the aorta, and they'll release right at this point. This is where they're going to release the contrast material. That contrast material, of course, will light up the coronary arteries, but the bulk of that material is actually going to flow through the aorta, down the descending aorta, and a bulk of it will end up directly in the kidneys, okay, where it can do damage to the kidneys. I also handed out, we're not going to spend time on this because it goes into too much detail. We don't have time to get into the physiology of what's going on, but I handed out a copy of this figure which goes through kind of the physiology of what's going on and how the contrast material is damaging the renal tubules. Acute Kidney Injury Network defines acute kidney injury as a 50% or greater increase in the serum level of creatinine within 48 hours of baseline. And that's what the authors of this study used as their definition of acute kidney injury. The incidence of acute kidney injury, or CI-AKI, is estimated between 3 and 15% of patients after undergoing a PCI procedure. CI-AKI results in an estimated additional cost of nearly $16,000 per patient, and that's not to mention the hardship that it brings to the patient and the loved ones having to deal with this unexpected complications related to kidney injury. The main point I want to make here is contrast-induced acute kidney injury is a significant healthcare problem, something we should focus on improving. So, what measures do we know of that improve or decrease the risk of developing CI-AKI? The authors of the study did a review of the literature and came up with a number of factors that have been proven scientifically through research to reduce the likelihood of developing acute kidney injury after a heart catheterization, exposure to contrast material. First and foremost, volume expansion, vascular volume expansion through hydration is the most important factor, and that's been known for some time. More recently, it's been discovered that oral volume expansion is as effective as intravenous volume expansion. That is, the patient can drink water, you can set the patient up with an IV, it's essentially about the same effect. And the authors indicate that oral and IV hydration should be paired for maximum fluid bolus. So you've got oral, you've got IV, and you can put the two together and get maximum benefit. Also, hydration with IV saline alone protects better against renal damage than saline with a diuretic. You might think, well, if working a lot of fluids through the kidneys is a good thing, let's give them a diuretic. That's actually been shown to not to be contraindicated. It actually is more likely to do damage to the kidneys with mannitol, for example, or furosemide on board. So we want to avoid that. A reduction in the volume of contrast media or contrast material used during the PCI lowers the risk of contrast-induced neuropathy. You can imagine if the contrast is nephrotoxic, exposure to less of it's a good thing. Also, it's been discovered that reduction in NPO time, that is, the amount of time in which the patient takes nothing by mouth prior to exposure to the contrast, is a good thing. Reduces acute kidney injury. So if you think about it, if we have an NPO for 8 hours prior to the procedure, that's 8 hours they're not drinking fluids. So if you can limit that number to, say, 2 to 4 hours prior, they're continuing to hydrate themselves just prior to the procedure. It's also been discovered that certain types of contrast material, specifically iso-osmolar contrast material, is less nephrotoxic than, say, low or high osmolar contrast material. Also, studies show that withholding potentially nephrotoxic medications prior to the procedure also reduces the risk of developing AKI as a result of exposure to contrast material. So those are the factors that we know decrease the risk of developing AKI following a percutaneous coronary intervention. What can the nurses do? And that is specifically what the study I cited looked at. This is it's a medical system in New England, and the nurses there got together and worked as a team to try and reduce acute kidney injury at this particular medical health system. So these are some of the interventions the nurses undertook. They obtained a commitment from the entire nursing team to implement the best practices we just covered for prevention of AKI after PCI. And the authors state that this was critical, that they had buy-in from the entire nursing team. So if they worked in the cath lab, if it was a nurse in the cath lab, they were on this team. If they were a nurse that provided patient callbacks, they were on this team. If it was a nurse in CCU, they were on this team that would receive patients afterwards. Telemetry, if you receive patients after a heart cath, they were on this team. So all nurses worked as a team. They selected a project leader they called the nurse champion that oversaw the project and stayed in contact with all members of the team. They conducted routine team meetings to discuss compliance with the practices, these best practices, and address any problems they were encountering and work to overcome those problems. They provided education to the clinicians. These nurses actually ensured the clinicians were on board with this. They worked to ensure the clinicians understood the importance of reducing CI-AKI. They worked to ensure that the clinicians administered the appropriate amount of intravenous saline. That would be prior to the procedure, a minimum of 500 milliliters. During the procedure, while the procedure is going on, 200 milliliters an hour minimum. And following the procedure, intravenous saline at a minimum of, or a minimum amount of 1,000 milliliters. With the physicians, they also stress the importance of withholding any nephrotoxic medications prior to procedures. They discussed with the clinicians the importance of choosing the least nephrotoxic of contrast material. They specified a maximum amount, based on research, a maximum amount of contrast material that could be used. And in the heart cath lab, on a whiteboard, when they did the timeout before the procedure, they would write down that number. So the physician was at all times aware of the maximum amount of contrast to be used. Anesthesiologists were encouraged to limit NPO time prior to the procedure. The goal was to limit it to 2 hours, so the patient's drinking 2 hours prior to the procedure. The acceptable range was 2 to 4 hours. The nurses provided patient education. The nurses partnered with the patient for shared responsibility in the prevention of CI-AKI. Patients were required to self-administer 2,000 milliliters of oral fluids 24 hours prior to hospital admission, and 1,000 milliliters of oral fluids in the 24 hours following the procedure. Patients reported early the day of the procedure for the IV saline hydration, and patients were instructed to hold any nephrotoxic medications the day prior to the procedure. Patient education was provided face-to-face through printed instructions that every patient was given to take home. A patient information pamphlet was available on the hospital website for backup, and a reminder phone call was placed to each of the patients prior to the procedure by 1 to 3 days prior to the procedure. They got a phone call. So what did they find? As a result of these interventions, the authors reported a 21% reduction in contrast-induced acute kidney injury following heart catheterizations. Based on this, I recommend we work to implement these same protocols in our local hospitals in order to reduce the incidence of CI-AKI locally. Any questions at this point?
When you say saline, do you mean 0.9% or 0.45%, or does it matter?
The authors refer to that as physiological saline, is how they refer to it, but they're talking about, you want the 0.9% saline, is specifically what they're referring to. Okay, now let's take the post-test and see what y'all learned.